Thank you very much. Acoustics in here aren't very good. And then I thought, well, it's like being in a church. And actually, it is a church. It's a big modern cathedral, isn't it, the Emirates Stadium? So, well, I'm from Scotland. We've abandoned the QOF. We don't have GP commissioning, prescription charges, a 7-day imperative, a junior doctor strike, or Jeremy Hunt. And there's only one of those things that I miss. Despite the differences, though, the challenges are similar, and we've a great deal in common. We've learnt a lot from the pioneering work at Tower Hamlets on cluster working between general practices. Now, in this slide, the 3 GPs from Govan, between them, have more than 60 years of cumulative knowledge and experience between them. A huge resource that we've tapped, capturing the experience and views of general practitioners at the deep end as an important source of evidence captured in more than 28 reports. They work in the most deprived 100 general practices in Scotland, where not only is life expectancy 10 years shorter, but healthy life expectancy ends nearly 20 years earlier. Patients spending twice as long in poor health before they die compared to affluent groups. General practice can't prevent health inequalities, but it can slow their progression and prevent premature complications, partly by applying what we know to work, the evidence-based medicine enshrined in the QOF, but also, and I think more, by the bread and butter of general practice, unconditional, personalised continuity of care for all patients, whatever condition or combination of conditions they have. The corollary is that if healthcare isn't equitable, with delivery based on need, then healthcare itself becomes one of Michael Marmot's social determinants of widening inequality. That's why GPs at the deep end argue that the health service should be at its best where it's needed most. No one would disagree with that. But this slide, published last November in the BJGP, caused a stir, at least in Scotland, although the situation it described is just as relevant and perhaps even more so in England. The population is divided in tenths across the bottom, most affluent on the left, most deprived on the right. Premature mortality in red more than doubles across the social spectrum, as does in blue premature multi-morbidity. General practice funding via the contract in black is virtually flat, especially in the poorer half. Consultation rates in green rise, but only by 20%, and that's because with no extra resource, consultation rates can only increase by shorter consultation times or working a longer day. And it's not just pockets of severe deprivation. 2 million Scots in the 40% most deprived areas receive £10 less GP funding per annum, that's about 8% less, than 3 million Scots in the 60% most affluent areas. I think you would find the same thing, if not worse, in England if you looked. We know from this study of 3,000 GP consultations in the west of Scotland that consultations in poor areas are characterised by more multi-morbidity and social complexity, less time, reduced expectations, less patient enablement, especially for those with mental health problems, and greater practitioner stress. This is 8 years ago, so things haven't got better. From 700 videoed consultations, we know that patients in poorer areas show less interest in shared decision-making, they perceive the doctors as being less empathetic, and they have poorer self-reported outcomes after 1 month. Tudor Hart's inverse care law is alive and well. It's not a law, it's a policy, And it's not the difference between good and bad care, it's the difference between what GPs can do and could do if they were better resourced. Can we afford equitable primary care? Given that we spend less per head on healthcare than any other Western European economy, as this US study showed, of course we can. Whether we have the will, that's another matter. The study of consultations showed something else. While patients could report practitioner empathy, did the GP listen, understand, care, know who you are, that sort of thing, although they could report practitioner empathy without being enabled, better able to cope, they never reported enablement without practitioner empathy. They never reported enablement without practitioner empathy. So relationships are the silver bullets of general practice and primary care. But these aren't the only relationships. We know that small shifts in the balance of care between primary and secondary, say from a ratio of 87 to 13 to 84 to 16, can be cataclysmic for hospitals, whilst being imperceptible in primary care. That's often described as gatekeeping. The irony of gatekeeping is that there's no gate, only an empty gateway, at least for unscheduled care, which patients can pass through at any time. What is it that keeps patients in the community? It's satisfaction and trust in the care that they receive, which primary care is able to provide, something that the NHS neglects at its peril. And something has gone badly wrong, as these Scottish data show. A sudden steep rise in emergency admissions after 2004. There are lots of possible reasons for this. A reduction in district nursing, a council tax freeze which reduces community care. But an ageing population isn't one of the explanations. Weakened general practice probably is, as this well-described 18% reduction in the GP funding as a proportion of NHS budget in the last decade, also true in England. I spent a day shadowing a GP in Scotland's most deprived general practice. I saw endemic multimorbidity and social complexity, the importance of previous encounters and shared knowledge for anything much to be achieved in a short space of time. The value of empathy and trust. I didn't see any worried well patients, but I did see a worried doctor, taking it upon herself to anticipate problems and take avoiding action. She set the bar high. Every patient mattered. Of course, in general practice, as in the film, nothing very much happens in brief encounters. It's the serial encounter that makes a difference. All the contacts a patient has, with starts, stops, successes, disappointments, distractions, restarts, and so on. In Tudor Hart's words, initially face-to-face, eventually side by side. For many patients, the middle-class mantras of self-help and self-management are destinations, not starting points. Just as Scheherazade made up a new story every day, her life depended on it, the business of general practice and primary care is about creating stories, building patients' knowledge and confidence in understanding and living with their conditions, and accessing the advice and services they need. Not everybody needs that type of care, but the 10% of patients with 4+ conditions probably do. They account for a third of unplanned admissions to hospital and a half of potentially preventable unplanned admissions. For a condition like high blood pressure, a few computer clicks will tell us not only what we've achieved, but what we haven't done. We have no such information about patient narratives. But a good starting point is to ask the patient, While previously he may have told us the diagnosis as we were taught in medical school, but increasingly she will tell us her treatment goals, which is a huge challenge to professional power and authority. Do longer consultations make a difference? The Care Plus study will be published soon, a randomized controlled trial of extra time for consultations, about an hour extra over a year, used mostly for a long initial encounter, resetting the agenda, plus additional support for patients and professionals. After 6 and 12 months with 90% response rates, patients receiving the extra time had better quality of life. Not so much because they improved, but because the control group got worse. And here's a hugely important message. Good general practice for patients with established conditions slows the rate of decline, enabling patients to live longer, better lives. And to use a football analogy, which may be appropriate in this setting, the aim isn't to win every game or to gain promotion, nice though that would be. It's to stay in the division, preferably in the top half, avoiding battles with relegation for as long as possible. And if everyone did that for every patient, health would improve and inequalities would narrow. That study shows that extra time for GP consultations is cost effective, well below the NICE threshold. A drug or technology with this cost effectiveness would sail into practice. We'll see. In his comic novel Cocoon, Spike Milligan described a man who invented a machine that did the work of 2 men. Unfortunately, it took 3 men to work it. The NHS in a nutshell. We have too many specialist services doing a small range of things, usually well, seeing themselves as hubs, as centers of their universes, but leaving lots for others, and especially general practice and patients, to do. It's a recipe for fragmentation. My colleague Francis Mayer and others have done a lot of work describing what they call the treatment burden, the work that patients have to do to live with a condition, understanding their treatments, accessing clinics, and so on. Too often the NHS increases the treatment burden, making life difficult for patients, especially those who lack knowledge, confidence, and agency, by what it requires of them in terms of accessing services. Patients with multimorbidity are hardest hit. This slide shows the commonest long-term conditions on the left. Each condition has a bar, and the first figure in each bar is the proportion of patients who only have that condition. In every case, they are a minority. Most patients have 2, 3 or more conditions. Almost the whole of evidence-based medicine is biased towards patients on the left-hand side. Multimorbidity can be trivial. The commonest comorbidity in an elderly person is hypertension. Hypertension and one other thing is multimorbidity by some definitions. That's why in the slide I showed you earlier on resources, we used complicated multimorbidity. That's 5+ conditions, or the combination of a physical and mental health problem. With its intrinsic essential features of contact, coverage, continuity, coordination, flexibility, long-term relationships, and trust, allied to an unconditional approach, general practice is the natural hub for local health systems. No other part of the public service has these features in such large measure. But although general practice is essential, it's not sufficient because of the need for links to so many other services and resources. What we've learned from deep-end GPs is that the links need to be local, quick, flexible, and familiar, with attached workers who will work to the needs of patients and practices, not external agendas, subscribing to the doctrine that your problem is our problem, helping to make a machine that does the work of two men that needs only one person to work it, strengthening the generalist function, keeping care close at hand. As the Don Berwick in the US put it, for the future, health practitioners need to ask not only what is it that I do and how well do I do it, but also what am I part of? How does what I do connect with what happened before and what will happen next? It would be good to see that in consultant appraisal. Health systems can be resource poor and people rich, think of Cuba, or resource rich and people poor, think of the US, countries with very similar health outcomes. Two health practitioners may serve the same community. Zero means they haven't heard of each other. One, they've heard of each other but have never met. Two, they've been in touch but don't work together. Three, they work together but haphazardly. Four, they sit down to review and plan their joint activity. Climbing that ladder for multiple relationships is the route to integrated care. So we need building programs. In Glasgow, we built the biggest acute general hospital in Europe, and some people are proud of it. But the building program we need now, as we've just heard, isn't based on bricks and mortar, but it's based on cultivating the relationships that build effective patient narratives, local health systems, machines that do the work of two men. That can't be done by so-called powerful people, can't be done by so-called clever people. Needs to be done by people who are streetwise, who know their communities and can work with the people in them over the long term. The London Olympics Open ceremony celebrated not only hospitals and nurses, but also the pioneers of Britain's industrial revolution, the men in top hats. People who knew how to combine raw materials, manpower, technology, and inventions in productive local systems. We need such leadership now, not to produce goods for sale, but to help people with multimorbidity live longer and better in the community. GPs and primary care teams are ideally placed to do this. Kaiser Permanente in the US is ahead of us in showing how family physicians need to be released from tasks that can be done by others in order to emphasize the autonomy, mastery, and purpose which drives professional satisfaction and morale. In the deep end, we've learned from the Bridge project linking practices knowledge of elderly patients to local resources for social and physical activity, we've learned that there's no blueprint to roll out or a logic plan beloved by technocrats, only a learning process in which customized local arrangements evolve by trial and error. The leaders of these changes will be part of a learning organization committed to the idea that the best anywhere should become the standard everywhere, achieving that by sharing experience, information, evidence, activity, and values. The story of Sisyphus pushing his boulder up the hill reminds us of three things. First, simply staying in the same place is hard work. Second, getting to a higher level needs extra resources. Third, if we disengage, current achievements could unravel, perhaps never to reach that level again. Echoing the previous speaker, the future needs to be imagined and fought for. It's not going to be served on a plate. GPs and primary care teams are in pole position. It's a choice and a challenge. Metaphorically, we need to invent a machine that does the work of two men but takes only one to work it. GPs and primary care teams can't do it on their own, but it's very unlikely that anyone without a generalist mindset can do it at all. Thank you.